Hello, everyone. I'm Jennifer Kolb, and I'm a third-year fellow at the University of Colorado, and it is my pleasure to introduce Dr. Samuel Hahn today. He is the current Advanced Endoscopy Fellow at the University of Colorado, and he is co-first author on the manuscript that we'll be discussing today, titled The Effect of Individualized Feedback on Learning Curves in EGD and Colonoscopy, a cluster randomized controlled trial. And this was actually the focus of Sam's thesis when he was a T32 fellow.
Thank you, Jen, for the really kind introduction. I first off want to thank you for interviewing me today, and I also want to thank Gastrointestinal Endoscopy for the opportunity to talk about our research. And I represent my co-first author, Dr. Joshua Obuck, our senior author, Dr. Sachin Wani, and all our co-authors on this paper. I would also like to thank the American College of Gastroenterology for funding this study as a clinical research award, as well as the Department of Medicine, who funded Dr. Wani as an outstanding early scholar, and the NIH, who funded my T32 fellowship.
Excellent. So let's dive into the study. So the Encompass study really focuses on examining feedback as a form of an educational intervention for learning EGD and colonoscopy. So tell us a little bit about how your group chose to have feedback really as the intervention to focus on.
Sure. So in education as a whole, feedback has always been viewed as a vital component to the learning process, and it's no different in learning EGD and colonoscopy. Feedback, however, can be difficult to give, to obtain, and as I'm sure you've experienced as a fellow, difficult to even ask for. First off, it's important to define feedback as an informed, objectivist appraisal of performance with explicit intention of improving clinical skills, which is where a lot of feedback can go wrong.
Absolutely. And so in your study, what kind of feedback exactly did you look at?
Yeah, so in this multi-center cluster randomized control trial, fellowships are randomized to receiving either structured feedback in addition to standard feedback at their institution, or standard feedback alone. Now, structured feedback came in the form of quarterly individualized learning curves, which are created from evaluations completed by attendings.
Excellent. And so these evaluations, just so we can make this clear for the audience, so after a fellow would do 25 either EGDs or colonoscopies, the next 5 cases or consecutive procedures were evaluated.
Exactly. And so, for example, colonoscopies numbers 26 through 30 would be evaluated, followed by numbers 55 to 60, etc. And these evaluations were all performed using the ACE tool.
So the ACE tool, or the Assessment of Competence in Endoscopy, was what you used in your study, and I think this is really important for our audience to know about the ACE tool. So tell us a little bit about the tool.
Sure. So as you well know from your recent editorial in GIE regarding the EGD ACE tool, the ACE tool is a validated tool for both EGD and colonoscopies that was developed by Dr. Sedlak's group out of Mayo Clinic, and is now officially endorsed by the ASGE for evaluation of EGD and colonoscopy. Essentially, it measures cognitive and hands-on skills using a 4-point grading system, 1 representing a novice and 4 representing superior performance. For EGD, the tool assesses 4 hands-on skills and 3 cognitive skills, and for colonoscopy, it assesses 7 hands-on skills and 7 technical skills.
Okay, and so you evaluated your trainees using the ACE tool, and then their scores were really analyzed using cumulative sum analysis. So this Q-sum analysis is a really important method that's used in a lot of educational studies. So could you tell our audience briefly about what Q-sum analysis is?
Absolutely. So the simple way to understand cumulative sum analysis is to think of receiving a reward for every successful procedure, which in this study we defined as a score of 3 or 4 on the ACE tool. So for every successful procedure, a trainee's learning curve takes a small negative deflection, moving towards a score of competency. However, the failure of an unsuccessful procedure, a score of 1 or 2 in the study, leads to a greater penalty away from a score of competency. So a trainee would need many more successful procedures than unsuccessful procedures to achieve competency.
Okay, and so in your structured feedback arm, your trainees received their learning curves every 3 months, and these curves really depicted their performance on each item in the ACE tool for EGD and for colonoscopy.
Exactly. So they saw their individual performance, and then they also saw their performance relative to their peers across the country. And so we also made these curves available to their program directors as well, but we did not mandate anything on the part of the trainee, program director, or fellowship in terms of how to respond to these learning curves. We simply made these learning curves available to them.
Okay, so every 3 months the intervention group would have their learning curves, but the trainees that were in the control arm, essentially, they just sort of received whatever form of feedback they were used to getting at their institution, so kind of whatever was standard.
Exactly, and so in the control arm, the trainees at the end of the year essentially got their learning curves.
Okay. And your main finding of the study actually suggests that there really was no difference in learning curves for the intervention versus the control arm. So what do we make of that? Does that really mean that feedback is ineffective in endoscopy training?
Yeah, so the main results of our study found that the only significant difference between the two arms was in overall cognitive skills in EGD, where the arm that received structure feedback had superior scores, but there wasn't any difference between the two arms in terms of overall technical skills for EGD, as well as overall technical and overall cognitive skills in colonoscopy, suggesting that structure feedback did not accelerate learning curves in a clinically meaningful manner. Now, before we dismiss feedback as an ineffective learning tool, it's important to discuss why this form of feedback may have been ineffective. As you, Jen, wrote in a paper in GIE this year detailing the evolving training of endoscopy in the era of millennial trainees, millennials feel most comfortable when receiving regular feedback with an open line of communication with their attendings. In our study, a couple of the issues that may have limited the efficacy of the feedback was the timing and the digital nature of the feedback. We gave quarterly feedback, not real-time or even daily feedback, and this simply may have been too long a delay for effective intervention. And then we really wanted to remove the emotional aspect of giving in-person feedback, but this likely didn't help build the ideal educational alliance between the trainer and trainee, where open communication exists between the fellow and the attending. Another issue may have been the learning curves themselves. While it may be beneficial for the trainees to have learning curves without any response to these curves, it's really unclear what kind of benefit would be expected. While we train program directors and trainees on how to interpret learning curves, any remediation or action plan were really left to the discretion of each program.
Got it. Yeah, and I think, I'm glad you highlighted that. We are learning quite a bit about sort of our generation of trainees and kind of how we want feedback and how we want that connection with our attendings. Another really novel aspect of your study is this concept of entrustment, which, we think of a little bit differently than competence. So can you comment on how you guys looked at entrustment?
Sure. So entrustment is one of those concepts that comes intuitively, but it's really hard to objectively assess. Mm-hmm. So the ACGME, or the Accreditation Council for Graduate Medical Education, which governs our fellowships, they indirectly require fellowships to measure entrustment in the form of EPAs, or entrustable professional activities, which are discrete skills that should be able to be performed at distinct stages of training. We wanted to delve into this topic a little bit more by simply ask attendings if they would trust a trainee with either remote supervision, where attendings are available but not necessarily in the procedure room, or if they would trust a trainee with independent practice, where they felt comfortable having the trainee perform the procedure by themselves. We then asked what factors led to those entrustment decisions, and we found that procedural competence, reliability, and truthfulness were the most important. I think what was surprising was the high proportion of entrustment with both remote supervision and independent practice, particularly when considering that most of the cumulative sum scores for the trainees didn't meet the threshold for achieving competence. And this certainly warrants future studies with a mixed methods design likely, but it likely suggests that entrustment and competence are viewed differently by trainers.
That is really interesting, and I think you're hitting on some important points that there probably is a difference that we really need to look at a little bit further. So awesome. Well, any take-home messages for our audience from your study?
Yeah, so looking past the results of the study, I really think that the most important aspect is how competence can be documented in GI fellows across the country. So we created a secure online assessment system using validated instruments. And one of the potential applications is for fellowships to all assess their fellows real-time using a similar system. So fellows can then check their progress in a continuous level, and working with their program directors, they can create individual specific training plans that address specific skills or deficiencies. And as you recently wrote in an editorial for GIE, we really need buy-in from either the ACGME or the major GI societies to start widespread implementation of formal assessment tools to provide objective assessments of training competence. Because in the end, our profession and our patients depend on our competence.
Absolutely. Well, this is a fantastic study and an excellent step towards all of those goals. And this concludes our author interview for gastrointestinal endoscopy. We thank Dr. Hahn and his co-authors for this contribution, and thanks to everyone for watching.